with the second session of ward rounds. Here we will take a case of missed abortion. So, this is a 32-year-old G3P2L2 patient who presented with a lower abdomen pain and spotting per vaginum and this 8 weeks of gestation by LMP. Her previous 2 deliveries were vaginal, both full term with no complications. So previous were normal without any complication, but here we are getting one triad of pain, bleeding or spotting, we can say, and amenorrhea, suggesting of ectopic also. But let's see the findings first. On examination, her vitals are stable. Pulse is 86 per minute, BP 120 by 78 mmHg, and she is afebrile. On abdominal examination, soft mild tenderness in the lower abdomen. Per speculum examination, minimal dark brown discharge seen. Os is closed. Per vaginum examination, uterus is 8 week size, mild cervical tenderness is present and fornices are free. On ultrasound finding, a gestational sac with no fetal or pole or yolk sac, mean sac diameter is 25 mm with no cardiac activity and there is no free fluid in the pelvis. So by this ultrasound findings, we are now clear that this is not a case of ectopic pregnancy. It is pointing towards a missed abortion. So missed abortion. Now it's your turn to ask question. So you have to ask when was her last menstrual period, her cycle been regular or not, was a transvaginal ultrasound done or only an abdominal scan, is there any history of pain radiation to shoulder, fainting or dizziness to rule out rupture or hemoperitoneum, what was her beta HCG level if done, has she had any history of previous abortions, DNC or ectopic pregnancy, any known risk factor for ectopic pregnancy like PID, tubal surgery or ICD use, what's the patient blood group and RH status, what's the patient HB level and any sign of anemia. Now it will be examiner turn to ask question to you. So examiner is asking to you, what is your provisional diagnosis and why? So my provisional diagnosis is missed abortion because 8-week gestation with G-sac more than 25 mm but no fetal pole or yolk sac, no cardiac activity seen on ultrasound, spotting per vaginum with closed os, stable vitals, no sign of acute bleeding or rupture. However, I would also consider ectopic pregnancy as a differential due to mild lower abdominal pain and cervical tenderness, no fetal pole despite an 8-week size uterus, but the absence of free fluid in the pelvis makes ectopic less likely. What will be your next step in managing this patient? So, I would start by confirming the diagnosis, repeat ultrasound with transvaginal approach for better clarity. Then serum beta HCG level, check if they are rising appropriately, doubling in 48 hours or plateauing. If missed abortion is confirmed, medical management, misoprostol regimen for medical evacuation. If surgical management is considered, in suction evacuation if medical management fails or heavy bleeding occurs. Expectant management if the patient is stable and prefers to wait for spontaneous expulsion. If ectopic pregnancy is suspected, then methotrexate therapy for unruptured smaller ectopic with stable vitals. Laparoscopy, laparotomy if there is a sign of any rupture and hemoperitoneum. Then third question will be, how will you counsel the patient regarding the medical versus surgical management of missed abortion? So first, for medical management, misoprostol, non-invasive, it can be done on the outpatient basis and 95% effective in the first trimester miscarriages, cramping and bleeding expected for the first few days, follow-up ultrasound needed to ensure the complete evacuation. For surgical management, which is for suction evacuation, we have to counsel it is a quick and definitive procedure indicated if heavy bleeding, infection or failure of medical management. It is associated with some risk like anesthesia related risk, uterine perforation and Asherman syndrome. Now, if this turns out to be an ectopic pregnancy, what surgical option do you have? So, first one I have is laparoscopic selfingostomy, which is for small unruptured ectopics if the tube can be preserved. Second one is laparoscopic selfinsectomy for ruptured ectopic or if the tube is damaged beyond repair. Third, laparotomy if the patient vital is unstable. So, laparoscopy only we have to do if the patient's vital is stable. Otherwise, we have to directly jump to laparotomy, and or there is significant hemoperitoneum, then laparotomy we have to do. Then fifth one is, how will you prevent the RH isoimmunization in this case? Check the patient blood group and RH status. If the patient is RH negative, administer NTD immunoglobulin 50 mcg before 12 weeks, 300 mcg after 12 weeks within 72 hours or of any bleeding or uterine manipulation. What follow-up will you advise after managing this case? So, serial beta HCG levels until they fall to less than 5 milli-international unit per ml if medical or the surgical evacuation was done. Ultrasound after 2 weeks to ensure complete evacuation. Contraception advised to avoid pregnancy for at least 3 months post miscarriage. And the counseling on the future pregnancy and risk of recurrent miscarriage. So this is the end of our this session. Thank you. Stay tuned for more lectures.